I think we should make a start now. There may be people who join us over the next few minutes. As I said to those that were already on the call, my name's Kevin Reynard. I'm the Medical Director with ESIST, and welcome to all of you. Just to let you know that this webinar will be recorded and will be posted later today on the ESIST YouTube channel. And will be able to be viewed there by you and colleagues as you wish. I'd like to welcome both Ben and Richard to the webinar. There are content experts here who are going to be talking through the issues that we're concerned with today. We're looking today largely at identifying patients who are, or how can you identify patients who are suitable for an accelerated discharge from hospital, and we're going to both be talking about the times or the opportunities that exist for doing this, and also the tools that can help us identify suitable patients. So can I, first of all, Ben and Richard, just get you to introduce yourselves? So Richard, do you want to go first?
Hi, I'm Richard Genever. I'm a consultant geriatrician at Chesterfield Royal Hospital, and I'm also a clinical associate with the Emergency Care Improvement Support Team.
And Ben?
Hi, I'm Ben Owens. I'm an emergency medicine consultant from Sherwood Forest Hospitals, and also a clinical associate with the ESIST. Okay,
thank you very much. And Crystal's noted in the chat that if we very much want to encourage participation from everyone joining us on the webinar, this usually works best by people posting questions in the chat, and we will, or I'll pose them to the speakers as we have appropriate opportunities to do that. So if we can just start off by, tell us, in your minds, why does this matter? Why is this issue important? Do you want to start off about that, Richard?
Thank you. Yeah, I guess the starting point is to think about the reasons to be in acute hospital. Hospital is often best thought of as a treatment in itself, and like any treatment, there are risks and there are benefits. And to make sure that our patients are on the right side of that risk-benefit ratio, we need to be sure that we're admitting the right people. And so really there are two true reasons that an acute hospital is the very best place for you to be. One is if you're very unwell and your risk of deterioration, particularly life-threatening deterioration, is significantly high. And then the other reason is if there's a treatment that you need that can only be given in an acute hospital. And if we keep that sort of focus in our minds, then everything else that we talk about today will sort of drive us towards those two things. We know that the longer people spend in hospital as well, the more control that we lose over their outcomes. So particularly frail older people, they're in hospital for long periods. By doing that, we essentially hand over control over their outcomes to more random factors. Ben, I don't know if you want to talk about, as well as the person themselves that's potentially at harm, who else might be at risk.
Yeah, absolutely, and it's the sort of the situation that we're in, and I think most healthcare systems are in, and this shows no sign of changing really, is that most hospitals in the UK, pretty much all of them, are very full. Most of them will have outlied patients on the wards. Most of them will have people backed up in their ED at least part of the week, and some certainly on that are holding ambulances at times or all the time. And obviously, if there are holding ambulances, then there are people in the community waiting for those ambulances. And the reality is there are no more beds. The hospitals building a new hospital takes a long time. And also the staff, if you have more beds open, you need more staff to look after them. So we're very much not saying here that if you do need to be in hospital, hospital's bad for you. Hospitals are really good for you, and that's if you're very sick and or need urgent treatment, absolutely. But if we look at someone who stays in hospital or gets admitted to hospital, doesn't need to be there, or stays in longer than they need to be there, they need to be there, then actually they're at risk of non-scopal infection. They're, Richard said, they're at risk of deconditioning, particularly the frail elderly, loss of confidence and the delays that puts in. But also, if there is then a person who's outlined onto the ward, we know that increases length of stay and issues. We also know if someone is then stuck in the ED waiting to get into that bed. So the person in the hospital is at risk of harm. The person in the ED for a very prolonged period, we know there's a risk of harm there. Then if there's then someone in an ambulance trying to get into that space in ED, they're not getting the care they need. They're stuck in the back of an ambulance. And therefore they're not having a great experience. And certainly the longer they sit there, that they're untreated, the risk of harm goes up. But also the really vulnerable person in the whole thing is the person in the community. And actually, if the person in the community can't get an ambulance coming to them, and by definition, these are your sickest or most frail people who can't get to hospital, and actually no care at all. We've certainly seen some really sad situations of people are waiting a long time for treatment. Is not great for anyone. So actually, the point of this, really, if we can identify those for early discharge or alternative treatment rather than admission, then actually it's better for the patient themselves, which is the main point, but it's better for the other patients. And the other thing is really important here, it's better for the staff, because all across the NHS staff are stretched, they're pressured, and actually every additional patient in a bed doesn't need to be there, puts additional pressure and stress on those staff as well, on the systems, and therefore, so it's in no one's interest to keep people longer than they need to be there.
Thanks, Ben. So if we were to think about the whole episode of care, really from the time that somebody has made a decision to admit right up until the time of when people are approaching their planned discharge, when do you think of the times when you're more likely to be able to or have a really target-rich environment for identifying groups of patients suitable for accelerated or rapid discharge? So do you want to pick up from your perspective first of all, Ben, towards the start?
Yeah, so I think when you're looking at people in the ED and you, so they get anyone obviously you wouldn't discharge someone home, they're going home. That's not it. So if whenever you think you're going to admit someone, there's the thing of just talking out about, are we certainly need to have a mission? Is there anything else we could do differently that would avoid that admission if that was in the patient's interest? So looking at ambulatory care, looking at community care, looking at putting someone through a hot clinic, putting somebody with outpatient follow-up, or just bringing them back to theatre or something with delayed date rather than admitting them on that day. Then there's tools you can use. So there's the criteria.
We can pick up in the tools in a second, but you've talked there about right at that time where the decision to admit made is an opportunity to sense check that. And in the episode of care, when do you think is the next point? Is it, should it be at the post-take review or? Yeah,
absolutely. So there's the decision to admit from an ED or from an admissions unit or from an ambulatory care unit. I want to put the patient in bed. Just double check it. A senior person being involved in that decision is always really important, I think. And also if locum staff involved, someone who works within the system who knows the alternatives is really important. There's also the post-take ward round, so people who come in the daytime or particularly overnight, where more junior staff are involved in this process, and there are fewer alternatives available. At the post-take ward round is another good point to say is actually stop here. Could we get this person home? Patient one as well, because actually once they leave that admissions unit, there's a ward move, there's a handover of care, which can cause delays and issues, but also for the frail elderly, if you leave an admissions unit, then your care package and things will be cancelled. So actually someone who just goes for 1 day admission past their admissions unit can be a 14-day admission if their care package is stood down. So yeah, and also there's the thing of people who are seen in ED or admissions areas, they get to the post-take ward round, they may have needed some treatment, there may have been some ambiguity about what was wrong with them in the first place. Usually the following day, with more information, a bit of time or a bit of treatment, and not in the middle of the night, you get a much better idea as to whether the person we thought might need an admission over the day before actually still needs it, because sometimes there's a point there we can go, actually, do you know what? It's not as bad as we thought, or you've responded to the treatment, that's a good time to get people out of hospital. And I definitely encourage that thought process rather than just following the line we originally planned.
And Rich, what are your thoughts about opportunities once people have penetrated more deeply into the secondary care system?
Yes, I definitely agree. The earlier the patient spell in hospital, the greater the potential impact of that intervention. It's a bit like making a small course correction in a boat. It could lead to a very different destination. So we've talked about the post-take ward round, but actually another point that can be really important is the day after the post-take ward round. Often post-take ward rounds are carried out in very high volume. People are at risk of things like decision fatigue. And so that next day is another really valuable opportunity for ward-based teams to say, well, let's look again. Have we actually got the right plan here? Were the things that were put in place yesterday still appropriate? And I think it's really important to emphasise that it's also never too late to make a difference to somebody's course by just asking the right questions, and we can talk about what those questions might be as we go along.
Oh, okay, thanks. So let's start off then, I think, where you were just getting to, Ben. So let's start at the point of admission. How can you identify people that might better be investigated or treated without admission to hospital?
I think the first thing is involving senior people in that process if you can. So junior doctors or say agency or agency staff will either not be aware of alternative submission if there are them, and their sort of balance of risk is they may see things going wrong that or overestimate severity of illness. So there's something in it. First of all, having senior people involved in that process as early as possible it is important. There's tools you can use to try and go through, a bit like if you went to theatre, you have a stop moment in a pre-op checklist. That can be for even minor surgery. Well, if you had a big decision like admitting someone to hospital, a brief moment of using a tool, going, hang on a minute, following the tool and saying, does this patient have capacity to be managed in a different way? And also, I think really crucially, asking the patient. We often forget about asking the patient what the patient wants, because we sometimes go, oh, well, they're at risk of deteriorating, they're at risk of falls, they're at risk of whatever it might be, and actually we don't always ask the patient and offer them a choice, whereas in elective care we would normally routinely say we could do an operation or not do an operation. If we didn't do the operation, this would be the risk, this would be the outcomes. So when someone's being admitted to the hospital, is actually talking that through the patient, because some people say, do you know what, I really don't want to come in today, or could I come back tomorrow, or what's the risk if I go home and take the tablet antibiotics versus the IV antibiotics or whatever else. Involving the patient in that decision would be a really important thing to do, and I think that. But there's the criteria to admit tool, which is a series of questions, which is just to screen out people very quickly who clearly do need admission. And this is not using a new score to work out who can go home. It's using a new score to work out who definitely needs to come in. So then, if after you decide to admit someone, it asks a series of questions: is the new score 4 or higher, or 3 in one parameter, not including temperature for a moment? Then they probably need, if you wanted to admit them, they probably need to come in, just admit them, follow a conversation with the patient, making sure they want to come in. The next question is, if their new scores are right, obviously, do they have an underlying pathology, which is immediate risk of life-threatening deterioration? So you could have, for example, you could have somebody who is having an MI, who, whilst they have very stable observations, clearly are at risk of arrhythmias, deterioration, further infarction, or death. And clearly, just because their obs are stable does not mean they're all okay to go home. Actually, what are the red flags, particularly vascular and hemorrhagic conditions are probably the biggest ones. Also, significant metabolic things like severe renal failure, DKA, Addisonian crisis are all examples of other things that are where someone needs, without immediate treatment, they'll go downhill quite rapidly within a couple of days. And it says imminent because obviously someone with cancer, who's a new diagnosis of cancer, is at risk of deterioration, but that's a long-term issue. It's not a short-term issue. The next question would be, it's really just a sense check. This is the important one, really. If they were not in an acute setting now, would you admit them to a bed? So really looking at, so somebody who came with painless jaundice, for example, which is a potential for pancreatic cancer or GI cancer. Actually, if they were seen by a GP, they may go, do you know what, I'm going to do a 2-week wait referral for this. So just because or someone's in an outpatient clinic seeing a gastroenterologist, they wouldn't go, I'm going to admit you've got painless jaundice. We go, you need an urgent CT and an urgent workup, but not necessarily into a bed. So would you, that sense check of, would I admit into an acute setting to a bed if I was not in the ED right now? The next question is, assume we do want to admit them, are they going to be treated today? So there are people that come into hospital, so people who are anemic who require blood transfusion, people who have ascites that need it draining, people that have a pleural effusion that might need it tapping, or someone who's going to have their wrist fixed, a fractured wrist, but it's now 10 at night. They're not going to fix that today. If it's not going to be there today, could we discharge that person early from the ED and bring them back to ambulatory care, to an ambulatory pathway, a hot clinic, to day case theatres, whatever else? So it's about early discharge is actually saying we can take them away from the, not admit them today and bring them back for a procedure within your clinic in a few days' time. If you're not going to treat them today, what's keeping them in? And the final question is really about, obviously there are clearly social reasons that people come into hospital, particularly in the out of hours period. So a frail old person at 2 in the morning who needs a bit of, to work out what their mobility is like, or work out what their social situation is, etc. Would discharge be possible if medical were followed by another team? This is really a sense check on actually if they could be followed up, could we do that? Or if not, could we actually make sure that person, if they do come in, is identified for rapid discharge the following morning? So there are particularly frail people who can't go home overnight. It's not a reasonable thing to do, but actually the question to do is if they're flagged up at the point of admission, so this is someone tomorrow morning with a bit of support, we might get out of the door tomorrow morning. So again, so they don't follow the system and get sucked into the system, by identifying them as a rapid early discharge potentially. And also another example of patients who may be suitable for sort of that rapid early turnaround are things like people who've taken overdoses, or people who need a period of observation for something, but after that period of observation is done, then their medical needs are done. So again, teeing up those people who are suitable for discharge first thing in the morning, once they've had their observation period done, it's something that's good to do from the very start. So ward teams, etc., know this one's going home unless there's a problem.
So how do you think this tool could be used? Could I use it to make judgments about the performance of individual cleanicians?
Absolutely no, and we wouldn't go through years and years of training if this job could be distilled down to a series of 4 or 5 questions. Absolutely not. I said the two things are, the tool is there to, if you're going to use the tool, you use it as a sense check, because as Richard just alluded to, post-take ward rounds, but also decisions for admission in a busy emergency department or a busy ambulatory care unit, you're doing a lot of decisions at a lot of time, particularly through the evening, people are getting tired. It's hard to think laterally, it's hard to think differently. And actually, if you're a junior doctor or a locum staff member, actually you may not consider an alternative because you don't know the alternatives as well. So the point of the tool really is, it will be to go, oh, this patient isn't that sick and they're not going to have a treatment today and they haven't got a really dangerous diagnosis, but they do need something, right? They might fall into the category of, and then you ask the question. And at that point, if you're asking the question of could we do something different, in some cases, well, we know you can't, because it's 4 in the morning, there's no alternative. If it's midday, you might go a weekday, oh, actually, perhaps we could bring them through this, perhaps we could do this. It should be about prompting the conversation, the thought process, rather than, it's definitely not a performance management tool. And yeah, the job we do is highly complex and also subjective at times, so it's definitely not something to manage people with. So
you said that this is highly complex, and you've come up with or talked to us about a series of simple questions. I'm sure that some clinicians would say, yeah, we do this already. This is, there'd be nobody who would get into my hospital without us considering these issues. What would be your response to that?
I think 2 things. I think is anything that has complexity in it, mistakes or missed opportunities got to come into play. Complexity plus busyness plus tiredness and stress. None of us make our best decisions in those scenarios. First of all, so in the middle of a busy late shift, so we're all with decision fatigue. We're all capable of missing an opportunity to do something different. We're all human, first of all. Secondly, more junior staff will not know the alternatives or not see the alternative. locum staff we talked about. So I think absolutely there is that. The second thing is we've audited this. I think every trust in the Midlands has audited this. Lots of other trusts around the country have audited this. An audit of 1,500 patients show that about 18% of patients didn't need admission, either because of a decision that was made when an alternative decision could have been made about with something that's already available, or if there was another service available or was a different time of day, actually that admission could be avoided. Looking at the data, it's probably an underestimate because obviously it depends how you interpret it when you do it. There's some say there were no social care admissions or suitable for SDEC that were omitted. Yet we know every hospital has social admissions. Every hospital talks about social admissions as one of the issues. So interpretation of the tool will be there. So we think, and even if of that 18%, a quarter or half of them, say 5 or 10% of the total admissions could be avoided, that's actually quite a significant number. For most trusts, that's 5 to 10 people a day, 5 to 10 people a day, given their length of stay being 1 to 5 days or more. That's a big number of bed days and differences. So the audit suggests, well, none of us are infallible, particularly with out-of-hours services and lack of ability, particularly with junior doctors making decisions out of hours, but also all of us making decisions when we're tired. I've gone home, certainly for a shift, at the end of the shift gone, oh, I could have done that. I got home at midnight thinking, I thought back, oh yeah, why didn't I do that? And we reflect on things. And so, yeah, none of us are perfect, and the data suggests that too. And therefore, until you look at it, you don't know.
So Richard, Ben's alluded to the fact that none of us are perfect, and the people who are making that admission decision, whether it's in the ED or an admissions unit or estate, wherever it is, it can be really, really challenging. And does it really matter if these patients come in and stay for one night?
So I think if they were coming in for just one night, it would matter less. But one of the things that we did with the audit was, so my trust, I followed up what happened to all of the people that were admitted that didn't meet the criteria for automatic admission. And so there were 9 patients. That was about, it was just over 30% of the patients that were admitted that day. And those people accounted for 55 bed days. So if you look at the average additional bed day usage, it was over 5 additional bed days per patient, which equated to, bearing in mind this was taken from 1 day's admissions, close to 2 wards worth of patients that were in hospital. And coming back to what I said about the longer people stay in, so some of those people, if you repeated this over a long enough period, you will find some people that end up staying in for a very long time. Every 100-day admission starts as a 1-day admission, and when you start having really long spells, that's when you lose that control over the outcomes. And I think that what we all want is increased control over delivering better outcomes. We want our clinical decisions to be able to translate into the outcomes that the people we're looking after have to get. So yes, it's not only important on that first day, but actually translates into very big differences to the number of people that are in hospital. I think a couple of things that's worth adding as well is, so if you're unfamiliar with the criteria to admit tool, the first thing to say about it is that you should only use it if you've made an initial decision to admit that person. We don't want people applying the tool when you've already applied a risk stratification and decided not to admit that person. So we don't want to create a load of extra work. And also with that in mind, the order that the questions come up in is designed to start with the most objective thing, which is the National Early Warning Score, and then go from there. And if you achieve any of those criteria, that's enough to sort of stop at that point. So we wouldn't want people, again, wasting valuable time asking themselves questions that aren't necessary. And then the final thing to say is that the tool absolutely does not override clinical decision making. So if a clinician who is seeing the patient feels that that they require admission and they can justify that, then that's absolutely fine. The tool is there simply to identify people that other options might be available for, but is definitely not there to override somebody's judgment on and where somebody sits in terms of risk.
You're on mute, Kevin.
Sorry, that I had my dogs barking, so I went. Apologies.
None of us are perfect, as I said.
So, what about patients that have made it to an inpatient ward? Can you use the same tool there?
So the same principles apply, but the questions that, as they're asked in the criteria to admit tool, we think probably don't fit quite as well to the inpatient setting. So there is another tool which looks and feels very, very similar to the criteria to admit tool, called the inpatient decision support tool, which looks at it from an inpatient point of view. It applies the same issues about what is the early warning score? Are they still at a high risk of deterioration? And probably for inpatients, the question that becomes incredibly powerful is, would you admit this person for this problem that we're talking about today? So that could be an investigation that they might need. It could be a minor clinical deterioration that you wouldn't have expected them to be admitted for, but often people are kept in for. Do they still need treatment today that cannot be given elsewhere? So it's essentially the same basic principles. If you picked up the wrong tool, the world wouldn't end. But yeah, there is a separate tool, and both of the tools can be found on the Future NHS website.
You're mute again, Kevin.
Muted again.
So in terms of using the tool and identifying constraints within your system, how can the tool help in that regard?
I think so. If we take that one, I think there's two things. So if you look at these, it refers to tools as closing gaps and opening minds. Opening minds bit is, could I make a different decision? Could I look at this differently? The closing gaps is that clearly we talked about there are people getting admitted to hospital because there's no alternative available. So actually part of this, if you start to look at them and audit your wards, or use the tools in board rounds or do audits, you'll find there are gaps in your service. There's no transport available out of ED after 10 at night. The SDEC is shut at the weekend. There's no blood transfusion service on a weekend, on any number of things so people who don't meet those criteria who are get admitted. The good question is, what would it have taken to avoid that admission? What would need to be in place? Now, sometimes they get in and something was available, but so SDEC, but it was full. You got a small SDEC unit, it's far too small, generates a business case for a bigger SDEC unit. Or if you had access to two-way referrals from ED or hot clinics for certain specialists, and actually you can't assess everything. No hospital will have every alternative to admission, but you can look at what would give us the biggest bang for the buck. So actually having a neurology clinic at 4 AM is probably not going to make a massive difference to your admissions and things. But actually one of the big things would be around access to virtual ward, access to step down of care, looking at OPAT services. Some OPAT services will only do once a day antibiotics, when actually some services do 3 times a day antibiotics. So you can start to build a case to understand what's within our gift now with a simple change in rules or simple change in availability, or what requires a business case to improve it. Because you can change your practice by changing your decision, but you can change your practice by changing your process. So using the tool and the audits to identify gaps in your process, look at the opportunity for it, should certainly give the trust scope to see where they're best placed to place their resource in terms of admission avoidance, given that no one can do everything.
Thanks, Ben. So Mike's asked a question that's particularly focused about with there being queues in most community pathways to support discharge, but we can open out this a bit more widely. Is how do you overcome the view that an acute bed is a place of safety? Who wants to pick that? Richard?
Yes, like start. So I can tell through the way that the question's asked that it's coming from a point of understanding that hospital isn't that place of safety. So one thing I found really useful is to just find a few patients that have been in hospital for about 4 weeks. So 4 weeks, by choosing those people, you are filtering out the people with the really weird and difficult to kind of fix problems. And people that have been in that sort of amount of time, you will see that they have had ups and downs in their path, and it won't take you very long to find people that have had deteriorations or effectively come to harm through their time in hospital. Another way of looking at it is anybody that's working in a place that's had a medically stable ward for discharge planning, where people go. All you have to do is just look at the outcomes for those people, and you will find a lot of people who deteriorate, and sadly some of them don't survive. So it's fairly easy to find evidence that hospital isn't a place of safety. I think the other important question, though, that this brings up is, so what we're talking about is identifying people that may not be best served by being in hospital, but the solutions may not be available at that particular moment in time. And in terms of things like downstream, whether it's rehab or other things like that in the community, it really needs an ICS approach to it. If we can use the tool to identify where the gaps are, then that can be a really powerful way of working within an ICS to say, well, look, actually, we've got this percentage of people who are admitted every day that the whole admission would be avoidable if we had this resource in place. So we could use it as a way of identifying those potential gaps. What's really important is it must never be used as a way of forcing people out of hospital that have care needs that simply cannot be met elsewhere. That would be totally going against the ethos of the tool, but it raises an important question.
I think just to come with that, I think as well. So you asked the point of the question is about changing the mindset. I think you've got to talk to your staff about it. Until we start to talk to our staff about it, they have to understand that. Staff aren't going to convince or speak to relatives and patients about that unless they understand it themselves. So actually talking about that is really important. That hospitals are great for you if you're really poorly. If you're not poorly, there's a risk, and the longer you're there, the greater that risk goes up. And also, it's just however nice our hospitals want to be, they're just a place where most people don't want to spend their time. And look at the last 1,000 days of life stuff with the frail elderly and that kind of thing. How many do you want to spend days you want to spend in the hospital? So talking to your staff about the risks of admission is really important. Supporting your staff when people get discharged, and someone comes back in, it's not called a failed discharge. It's actually just someone got readmitted. It's a readmission. There's multiple reasons for that. It may be what the patient wanted. It may be the right thing to do at the time. It may not. But the language we use is really important, because staff, if they feel like they've been criticised for discharging someone a bit earlier, they're less likely to do it. I think it's honest conversation with patients, and I go back to what I said before about consent. So our job is to give people the facts and let them choose appropriate treatments based on that. So at the front door, I'll often have a conversation. A common question is, but my mother's fallen. They might fall again. If they come in tonight, I'll feel much more reassured that they're not going to fall. And the two things is, one is the evidence is if you come into hospital, you're probably more like your falls risk goes up because of deconditioning. We also know if you fall within a hospital, you're on a concrete floor, and if you hit a concrete floor and you're frail, you're more likely to fracture. So you're more likely to fall, and you're more likely to fracture. Yes, someone will find you. Absolutely, you'll not be on your own. Someone will find you, but the actual risk of the fall doesn't go. And sometimes they say, well, they're just admitted for one night, and then the next day, but that doesn't change anything tomorrow. So it's about having the honest conversation of, if they're admitted, there's a risk of non-scopal infection, poor quality sleep, all those things, losing their care package if it's more than 24 hours. Is that honest conversation from an admission point of view? And I think on the wards, it's the same thing, is actually saying to people, look, this is your choice. You can choose to go home here. We shouldn't tell you you're not safe to go home. It's a conversation. As long as I have capacity, it's the patient's choice. And the brand tool is a really good tool to use, which is, when you talk to a patient, what are the benefits of staying in or going home? What are the risks of staying or going home? What are the alternatives? Could we bring you back to a clinic? Could we put you on a virtual ward? Could we plug into community services? What if we do nothing and do what we're doing now? And at least if we do that, we're having an informed discussion with the patient about the choices involved. And it also pushes you as a clinician, I found this, it pushes me as a clinician to think about the alternatives and risks involved too. So using tools and things like that, just to have to challenge your own thinking, but also your conversation with the patient can shift some of that. Well, not deep-seated. I can't change what you think, but I can try and influence it. So it's about that conversation, but absolutely talking to your staff about the risks of being in hospital and the benefits of being at home. We haven't always been great at that in the past, but we've got an opportunity to change that.
And I'll just have a quick sort of word on why the hospital environment is, potentially so sort of toxic to frail older people. So I remember being at a talk from a psychiatrist called Liz Sampson, who described the sort of things that might be difficult for people to live with. So a lack of exercise and movement, intermittent noise and light control, environmental manipulation, controlled fear, disorientation, sensory deprivation. I remember thinking, gosh, yeah, that is really awful. And it was at this point that she pointed out that she wasn't describing a hospital. Those words were taken from a report from the International Red Cross about Guantanamo Bay. So it really puts in perspective, how serious is the environment we put people into. Ben, you've often talked about the sort of TripAdvisor test of, if you'd been on holiday somewhere and you turned up and there were 5 strangers in the room with you, and you had to, use a toilet behind a curtain, and the lights were on and a buzzer's going all night. It's no surprise that, particularly frail older people find it challenging, because I certainly would.
Thank you. So just moving on, just to expand Samantha's question a little bit. So the question's about identifying the resources, available resources to support this admission avoidance or early discharge. But if we can expand that to include, how do you maintain awareness of these once you've identified this amongst the decision-making staff?
To pick that up a little bit, one of the things we'd recommend is every trust will have, and every trust and the community around them will have a number of ambulatory pathways, alternatives to admissions, community support teams, hot clinics, virtual wards, and it's almost impossible. It is impossible to keep track of all of them. And as an emergency physician, I've got a fair grasp, but I cover a lot of different specialties in my interaction. If you work for an individual, I don't know them all. If you work for an individual specialty, so you're a gastroenterologist or a cardiologist or a surgeon, you work much more within your specialty. You can't possibly know there's a retention pathway for outpatients. People don't, medical patients go into retention, don't just stay in for there's a pathway for that. People on surgical wards, there's a DVT pathway for outpatients. If someone's a surgical post-op patient gets a swollen calf on a Friday afternoon, they have to stay until Monday morning for a Doppler. They could be still discharged and brought back to a DVT clinic, etc. So having a DOS or directory of services of the services available within your trust, but also outside your trust, easy accessible on the intranet, but also particularly your flow team, your matrons, your senior medics, knowing these things are available, so they can ask the question and make it also, I think crucially, you've got to make it easy to do the right thing. So making it easy to refer into these pathways. Sometimes these pathways are closed off to inpatients, and you think, well, why? There's no reason why not. There's equity of access for patients, but secondly, or if it, I think Richard said this before as well, if it takes more than 20 minutes to refer someone to something, you're probably unlikely to do it. So you have to make these pathways accessible, be that from the front door or from inpatients. It's got to be something that's relatively easy to do or to ask someone to do. Otherwise, when people are busy, they'll try. I tried that, it took too long, I didn't have time, and it doesn't happen. So having a DOS, making it available, educating your staff, but also making sure it's easy to do, as easy as it can be, is really important. And
if I just add to that, I'm going to just share one slide, which is some results from the Midlands Audit, showing the kind of things that we found were most likely to be alternatives to admission. So the biggest group was ambulatory things, so that's the combination of SDEC, perhaps hot clinics, maybe a diagnostic virtual ward, all those sorts of things, group them together. They're the biggest thing. Access to a specialist opinion was the next big one, and then I think it's really interesting that the third biggest was just making a decision to discharge them. No special service, just not keeping that person in. And actually you have to come down to the fourth one before it's social care. So that was less than 15% of the 1,500 people that came in, or sorry, less than 50% of the ones that we felt admission was avoidable. And there was one particular trust that felt that they could have prevented a few admissions through access to GP appointments. But the message that came through from this is actually we're probably not looking at something that's going to put increasing demand on community services or primary care. A lot of it can be done by just making a different decision about the people that we admit and just choosing to discharge them. And it's important to remember that you know, medical science evolves. So it's not all that long ago that people were admitted for initiation of drugs like ACE inhibitors. So it's all about, you know, where are we going next? What's the next condition that we don't necessarily need to keep people in hospital for? But yeah, the evidence that we've got seems to suggest that it shouldn't create enormous burden on community services. Now, your SDEC offer or your hot clinic offer or your specialist opinion offer may not be ready to take on all of the referrals that could come your way, but that's where the opportunity comes. It's about, in each individual trust, working out where your biggest gains are, where are the lowest hanging fruit that would be easiest to make a difference to, and starting with that, and then thinking about the stuff that may be a little bit more tricky.
And to follow up on that, Richard's comment there, I think a good example of how things have changed dramatically. So 10 years ago, 5 years ago, it was unheard of or very, very rare to manage a PE as an outpatient. They were all admitted, they were all scanned, they were all kept in. And now most trusts, most places, 90% of them are managed as outpatients. Same with people used to come and have their appendix out and spend a week in hospital. Now often they're home, if the operation goes home today, they're home the next day. And that's not placed a huge additional burden on primary care. So our knowledge of our care has improved, but also our understanding of actually either identifying those that do need to stay in, or being able to manage them in a different way. So one of the reasons PEs are managed that way is because there was no ambulatory care. Now, as ambulatory care services, we realise that most PEs are all right, or query PEs are right. That actually most of them can be managed. So it is always evolving and it is always changing, and we'd be still putting leech on people's foreheads for headaches if it hadn't. So I think the other thing that I think is really useful to look at is when you do admit people is around, there's the 4 questions. People have heard of that. So every patient and the staff looking after them should know what is wrong with me or what is being excluded, which helps you to focus on the original problem rather than, as Richard mentioned, things like, oh, the secondary problem occurred, we've found some, you're in with this, now we found this. What is being excluded? What like or what am I being treated for? Second question is, so what am I being treated for? What is going to happen to me today to get me home or get me better? If nothing's happening today, get me home to better, there's a good question. Okay, so a good question, why am I here? And the patient should know that. Everything going to plan. When should I, at the earliest time I should expect to go home? So aligning your staff and your patient's thoughts to getting people home. And Christmas is the perfect example of that, when all the staff, the relatives and the patient all want to go home by a certain day. As if by magic, every Christmas the occupancy of the hospital dives down dramatically, but everyone's working to the same goal. We do this at Christmas every time. So when you align staff, patients and relatives with the same goal to get someone home, it's much more likely to happen. And they're the key things really, in terms of making sure that if everyone's working to the same goal, then actually people are much more likely to get home. And who would argue you shouldn't know those things as a patient, and the staff looking after them should clearly know what's wrong with them, what's going to happen today, what do I need to achieve to go home. So if you have to walk to the toilet and back to go home, you've got to walk to the toilet and back, etc. And what day should I go home? So all those things are tips to try and identify people on EDDs and things like that, are people who are getting close to that date or past that date. Why are they still here? Have we missed something? Have they got worse? Or are we now investigating something else that wasn't the real reason they were in hospital in the first place? But while they're here, we're also looking at that as well.
So if we just go back to thinking about the patients who have moved past those early stages and in a base ward or a deeper inpatient ward, how can huddles help to move this agenda on, identifying patients who could go home?
Yes, I think huddles are incredibly powerful tools to try and make sure that we understand what's going on with every patient that's in hospital, They only really work if somebody's asking the right questions. So it's really trying to understand whether this person needs to be in hospital. Literally, sometimes saying, why is this person in hospital right now? That can be really a helpful thing. I think huddles work best when the information that is shared is specific and that there is transparency. So by specific, I mean things like not saying things like for social sort or the blanket OT/physiotherapy. It's about defining what it is that that person needs to be able to do in order to be at home. One of the things I found really helpful is making sure that your huddle has a memory. So something that tells you about what happened yesterday. It means that the conversation is much more dynamic. Did this happen? Did that happen? Also, it's just a bit embarrassing if for the third day we're talking about the same thing that needed doing, and so it really just helps people to focus on the fact that all of these things do matter and they do make a difference. It also helps to take away from, there is this assumption if you're working in secondary care that all the problems are in social care, and actually if we could sort that out then we'd be okay. And actually you realise by having a memory with your huddles that actually a lot of tasks do get carried over to the next day, and then that knocks on to affecting the expected data discharge or the real data discharge. I can see that, all right, Kevin, you're back, so that's good. In terms of setting expected data discharge, I would strongly advise using a clinically defined expected data discharge. What is the earliest possible date that, if, as Ben said, that if everything went as well as possible, that we wouldn't need inpatient care anymore? And then what we're trying to do is align everything else up with that. So think about it like a wedding invitation. So if you know that there's a wedding at a certain date and a certain time in a particular town in the country, you know that if you've got to get there, that you will have to set off before a certain time. And if you set off later than that, even though it's before the expected date of the wedding, you will be late. And so using the same sort of approach to aligning the non-medical with the medical things can help to push that date forward. I did see a question come in about whether huddles and board rounds mean the same. I think they more or less are the same to my mind. I think what we're talking about is a rapid discussion which is task focused, multidisciplinary, and where we are. The other thing to do is to set the priorities. So many of you will be familiar with the SHOP mnemonics. So see the sick people first, then the people that might go home, then the other patients, and then make sure your plans are shared. So I think, yeah, I wouldn't get too hung up about whether they're called board rounds or huddles or whatever where you are.
Just to pick up one of the other comments in the chat, and it's from Samantha about admission avoidance experience with limited care and staff, and everywhere is limited, isn't it? I think it's a really good point. I think one of the things we can get better as a system is non-conveyance to hospital or alternatives to conveyance to hospital admission avoidance. And two things that stick out. I think people in care homes or things that could wait to come to an ED in the daytime hours rather than coming at 4 in the morning when actually more junior staff around and times are delayed and things. But that's the other thing is end of life things, and actually we can treat lots and lots of things. The question is, should we treat for the frail elderly in care homes and things, and actually saying this person is very frail and old, particularly when they become bedbound and that kind of thing. I'm not saying we shouldn't treat anyone at all, but actually asking that question, what would this person have wanted, or what do they want before we go ambulance hospital? Because we know if you get into the ambulance hospital scenario, then you get, if it's basically out of hours, you see a junior doctor, you're likely to get IV fluid sepsis treatment, and admitted is this sort of classic sort of system there. And the question is always, should they be conveyed, or if they hit the front door, or what does the patient want? Is this something we can be treating? Is this someone in there who's deteriorating in the last few days of their life, and actually what should we be doing? And I think that's really important, a question to ask. So that advanced care plan, that honest conversation with families and asking that question, what would the patient have wanted if they haven't got capacity? is really important. So mission avoidance I see too many people coming into hospital who are clearly at the very end of their life, and we're treating something that it may prolong the inevitable by hours to days, but that's it. Actually, if the patient wouldn't want that, why are we doing it? So there's something around in that around admission avoidance in the community, and also community falls and that sort of thing. We're very good at the front door at going, oh, you need to see a therapist. If someone falls over, I always ask myself a question in ED, if I was a GP, what would a GP do? If someone was a GP had someone who fell over in their home and got back on their feet again, they wouldn't say, right, you have to sit down in a chair now till a therapist comes to sign you off to walk. But that's what we do in hospitals if someone happens. So actually, there is something very much in actually testing what would a GP do in this situation. And it's often not, I would get a therapist and keep you bedbound overnight till the therapy team comes. They would say, community falls teams here, are they mobilising themselves? Yes, they are, fine, we'll get you plugged into it. So actually testing yourself, what would someone else do? So if you're an inpatient, what would the front door team do? If you're an ED person, what would a GP do with this? And actually, it's just a good sense check of your decision making again. And that's, of course, what does the patient want, aware of the risks?
Thanks, Ben. So just the last thing that we'll pick up on before we close is in terms of Mike's question about medical engagement with board rounds and huddles. Do you think the solutions to this are structural, so around ward-based medical teams? Is it about job planning? Is it about cultural aspects or perception of value of board rounds? What are your thoughts about it?
I think it's all of those things. I think there is no doubt that it's a lot easier to run huddles or board rounds if you've got a clinical team that is based in the same space as the huddle you're doing. So it definitely simplifies things. Having said that, I think there are a lot of assumptions that people cling on to that are not necessarily correct. So we operate, I like to call it the head chef model on our ward. So rather than a consultant seeing their patients and only their patients, what we do is the consultant that's visiting the ward that day does a huddle for all of the patients on the ward, whoever they're under, and sees the people that need a consultant's input. So for me, that might mean that on a particular day, I might only see 3 patients, but they're 3 patients that need really difficult things that only a consultant can legitimately do. And then all the other patients are seen by people who have the skills to do that. So that's one thing to do. And I think, I haven't tested this idea out, but I think that if you have people that are skilled in leading a huddle, they wouldn't even necessarily need to be from the exact speciality that patient is under, because what the huddle will often do is just create the questions for that day. So if I were to lead a huddle on an orthopedic ward, I would say things like, okay, is this person allowed to weight bear? And I might not know the answer to that question myself, but that's the right question for that day. So I do think there is a way where, particularly where you've got wards where you've got maybe 6 clinical teams that all use the same ward, where you could have a single huddle that is meaningful, but only if you've got people who kind of believe in it and are determined to kind of really push it and ask the right questions.
And just to follow up on that, I think I've recently done a big look at all the inpatients in my own trust with a big MDT team. Actually, the quality of the plan you make. If you make a plan aligned to the 4 questions, so what's wrong, what's going to happen, what the criteria for discharge, then actually it matters much less whether you know the patient in detail when you're leading those huddles and making those decisions. And the same goes for weekend plans. Obviously, discharges tend to tail off in most trusts over the weekend, and actually, if you made a really clear plan in the notes, what they have to do to get home, what they're waiting for, what they need, etc., then it's easy if you're a visiting doctor to make a decision on that patient. If the plan is not clear, or is await bloods, or is get CT, or continue antibiotics without saying how long for, or what the criteria to come off them would be, etc., then actually you've got to make it easy to do the right thing again. So if the plan is good and the team knows the plan, the patient knows the plan, your chance of success got to be much greater. And actually, if you're a visiting registrar, consultant, senior nurse, whatever else, it makes the decision making so much easier. And if it's easy, it's more likely to happen. Go on mute again, Kevin.
No, so thank you very much, Ben. So that I think nicely brings us to a conclusion. So thank you very much, Ben and Richard, for talking to all of us today. Ben's just mentioned about weekend discharges, and whilst this webinar is the end of this series of webinars, the next series of webinars starts on Thursday, and the first one of those is about weekend discharges. So thank you very much for the link into that one, Ben. For those people that have joined the webinar, Crystal's just about to post a link for feedback about the webinars. It's very, very useful for us to get feedback. It takes a couple of minutes to do, so we'd be really, really grateful if you would do that. So once again, thank you very much for joining us. I hope you found it useful, and we hope to see you again on another of our webinars. Thank you.